Welcome to our podcast, SGLT-2 Inhibitors Morning Commute, Widening Benefit. Morning Commute is developed in collaboration with AtPointOfCare and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Boehringer Ingelheim Pharmaceuticals and Eli Lilly and Company. In our previous podcast, we looked at SGLT-2 inhibitors and their effect on chronic kidney disease in patients with type 2 diabetes. These treatments are showing a wide benefit beyond glycemic control. In this episode, Dr. James Januzzi and Dr. Silvio Inzucchi will discuss SGLT-2 inhibition in cardiovascular risk reduction by taking a look at some of the pivotal clinical trial data. Information about the faculty and disclosures can be found at morningcommutepodcast.com/SGLT2 inhibitors 4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Januzzi is a member of the Cardiology Division of Massachusetts General Hospital and is the Hutter Family Professor of Medicine at Harvard Medical School in Boston. Dr. Silvio Inzucchi is Medical Director of the Yale Diabetes Center and is a Professor of Medicine at Yale School of Medicine in New Haven, Connecticut. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Januzzi will begin our discussion.
So this is Jim Januzzi. I'm glad to be here and speaking with my colleague, Dr. Silvio Inzucchi. So Silvio, great to be talking with you on this subject. This is obviously an area that's been changing dramatically over the last few years, and the SGLT2 inhibitors have become the next really big thing at the interface of cardiology and diabetes, primary care, and other specialties. So I'm really glad to be able to talk with you about this. I guess the first question I'd ask, because what we've learned about SGLT2 inhibitors came from the so-called cardiovascular outcomes trials. So I guess why don't we start first with how in the world did we get here? How did we get from a reasonably effective diabetes drug to this real game changer therapy that crosses all sorts of disciplines? Well, maybe you can bring the audience along a little bit on this.
Well, it's really an important historical point because if you asked me 6 or 7 years ago, would we ever find a specific glucose-lowering agent that could have such a dramatic effect on cardiovascular outcomes, I would say it would be hopeless because we had been through decades of trials, both assessing glucose lowering itself and then specific drugs. And it's been very, very difficult to find any impact of either glucose lowering or specific glucose lowering drugs on cardiovascular events. And I think at some point, endocrinologists have become hopeless that we would ever find such an agent to do both things. Now, obviously, we can improve cardiovascular outcomes in diabetic patients with lipid-lowering therapy, good blood pressure control, but it had been the holy grail in our field for a long time to find a specific agent that could actually do both, treat the diabetes, but also have an impact on cardiovascular events.
So, and before you get to the SGLT2 inhibitors, it might be helpful for people to understand the background of therapies that failed or even increased risk. So the path to the SGLT2 inhibitor class may be a little clearer.
Well, for years, obviously, Jim, we had insulin and sulfonylureas. And in fact, when I first began training, we did not even have metformin as a glucose-lowering drug.
I remember those days, Sylvia.
When you look at those trials that have tested SUs and insulin, routinely they were neutral for cardiovascular events. Some observational studies suggested at one point that the sulfonylureas could actually increase the risk of cardiovascular mortality, but actually when submitted to carefully done clinical trials, they appear neutral. So they're terrific for lowering glucose and for reducing microvascular complications, but no impact on cardiovascular events at all. Metformin, I think the verdict remains still out on a drug that's now about 30 years old. Now, there are some studies from the 1990s that suggested a benefit on non-fatal myocardial infarction. But those data sets are not robust at all. Small studies, pre-statin era. I really don't think we'll ever know whether metformin is a cardiovascular friendly drug. The TZDs came along in the mid-1990s, And there you have a bit of a double-edged sword. They came onto the market as insulin sensitizers and therefore had the hope of reducing cardiovascular events. But as you probably recall, one of the drugs, pioglitazone, probably does reduce MACE. It may have some anti-atherosclerotic properties. But the other edge of the sword is this impact on renal sodium handling that leads to an increase in volume. And in certain individuals, a lot of them obviously have diabetes and maybe early HFpEF could develop heart failure. So you might reduce ischemic events, but increase the risk if you're not careful of heart failure. So, where is the net balance of using a TCD? And then came the alphabet soup of diabetes treatments, right? The DPP-4s, the GLP-1s, and the SGLT-2s. And at that point in time, the FDA had become very concerned, and the story is complex, and I don't think we have time to get into it, but there had been some studies and some meta-analyses that suggested, if anything, that drugs that lower glucose could actually have the opposite effect, could actually increase ischemic events. So the FDA really put its foot down in about 2008, 2009, and began mandating these large cardiovascular outcome trials, initially designed as safety trials to be sure that these new drugs coming down the pike to lower glucose didn't worsen cardiovascular outcomes.
Yeah, and that's really in some ways a landmark moment, because it's reasonable to suspect that had the FDA not put these expectations in place, we would never have come across the benefits as conclusively as we have for the SGLT2 inhibitors. We probably would have eventually, but with respect to the resounding success of the first of the CVOTs, which we'll talk about in a second, that really opened the door for subsequent findings. Now, it's important for the listeners to remember that these cardiovascular outcomes trials, as you say, were designed for safety. As well, they were focused more on the so-called atherothrombotic complications. So
Correct.
non-fatal MI, non-fatal stroke, and cardiovascular death is the so-called triple MACE. Mm-hmm. And so there were still some questions that obviously were not answered by the CVOTs, the cardiovascular outcomes trials, but that obviously opened the door for studies and even after. But why don't we start first with the first data that came through for empagliflozin from the first of the CVOTs, that being the EMPA-REG outcome study.
Sure. That was a 7,000 plus patient study that really got the ball rolling. It was initially announced back in 2015, and the results were quite shocking. This is the first time that any glucose-lowering medication had been associated with a clear cardiovascular benefit in a high-risk population of patients. All the patients had overt cardiovascular disease, and the 3-point MACE outcome was reduced by 14%. Not actually a home run, but when you drill down on the components of 3-point MACE, there was this surprising, huge benefit on cardiovascular mortality, which obviously may be the most important component of MACE. It was a 38% reduction in cardiovascular death. And that is something that we've never seen in diabetes trials. In fact, it's hard to show such an effect on CV death, even in lipid-lowering trials, as you know. And then the secondary outcome, and as you pointed out, we were super focused on atherothrombosis. So we, along with the FDA, went along with the 3-point MACE as being the primary outcome. But the secondary outcome of heart failure hospitalization, an increasingly important outcome in diabetes trials, that was reduced by 35%. And to date, none of the other medications have shown any beneficial impact on heart failure. And as mentioned before, the TZDs, if anything, increased heart failure hospitalizations, as did one of the DPP-4 inhibitors, saxagliptin. But between the cardiovascular mortality benefit, the heart failure hospitalization benefit, and also this interesting improvement in CKD progression, also on the order of 35 to 40%. It was really an impressive study, the first in a series of SGLT2 inhibitor trials disclosing the surprising benefit, or I should say benefits, because of the renal impact as well.
Yeah, that's really a great summary of the landmark first study that came out, EMPA-REG outcome. So in order to provide some context for the listeners, and the ability to sort of think about the other trials that we'll discuss in a moment, can you describe who was in the EMPA-REG outcome study? Who were these patients?
So obviously in these cardiovascular safety trials, you want to conduct them during a few years, right? A certain reasonable period of time. And therefore you want to focus in on a high-risk group of patients in order to accumulate enough events to confirm indeed safety of these newer diabetes medications. In fact, the FDA strongly suggested that we would be focused, at least with the initial trials, on a high-risk cohort. So every patient in EMPA-REG outcome had established cardiovascular disease. Many had prior myocardial infarction, previous bypass surgery, PCI, strokes, peripheral arterial disease. Only 10% actually had heart failure, but more than 99% actually had overt atherosclerotic cardiovascular disease.
Yeah, that's really an important point because we can start drawing some comparisons to other trials in a moment. The other thing, of course, to get patients into the study was that they needed to, in addition to their usual diabetes care, they had a hemoglobin A1C of 7% or greater. And that'll be an important point when we start talking about in whom we might want to think about using these drugs, right? But so EMPA-REG outcome, big effect on CV death, big effect on a secondary endpoint that wasn't really considered all that in depth, at least. We adjudicated, I was on the endpoint committee for EMPA-REG. We adjudicated heart failure, of course, but we didn't have ejection fractions. We didn't have a very comprehensive background on these patients, but nonetheless, a really important finding. The second cardiovascular outcomes trial to land was the CANVAS study. And what was seen there?
Well, that was with canagliflozin, and it's a bit different than EMPA-REG because they did include, I believe it's about 20% of patients had high-risk features for cardiovascular disease, with 80% having established cardiovascular disease. Interestingly, the MACE endpoint was exactly the same, 14%. You rarely see that in two trials with two different drugs, although obviously of the same class. Now, the cardiovascular mortality endpoint was not statistically significantly reduced. I think the hazard ratio was 0.87, but they also saw this, again, very striking effect on heart failure hospitalization of 33% relative risk reduction. And also, their definition was a bit different, but this progression of chronic kidney disease was reduced by almost exactly the same, by about 40%. So the thumbprint, if you will, of this class of medication is quickly emerging, that there is a consistent benefit on heart failure, both in established heart failure patients. Again, only 10% in EMPA-REG had heart failure. I believe a few percent more in CANVAS may have had heart failure, but the overwhelming population in both of these trials did not have baseline heart failure. And even in that population, there was prevention of heart failure hospitalization, which obviously means you're preventing heart failure, not treating heart failure progression, but actually preventing patients from getting heart failure to begin with.
From developing incident heart failure, yeah.
Right.
And there are some really interesting epidemiologic data showing that, while atherothrombotic disease is very important, obviously, in patients with diabetes, it's that combination of chronic kidney disease and heart muscle disease that predicts progression to heart failure in patients with type 2 diabetes. And so this intersection of benefit on progression of CKD together with reduction in heart failure is really a dramatic effect of SGLT2 inhibitors, and obviously very important. Now, again, in the CANVAS study, these were patients with type 2 diabetes, A1C over 7, and in EMPA-REG outcome and in the CANVAS study, two different dose levels of the SGLT2s were examined, but it seemed that it didn't matter which dose the patients received, high dose or low dose for each. So EMPA 25 versus 10, or 300 and 100 for CANA. After those results came out and that heart failure impact was seen, the investigators for the DECLARE study scrambled and added a heart failure endpoint to their study, which had not yet completed. Do you want to unpack the DECLARE study for people, please?
Yeah, as you pointed out, initially they started with 3-point MACE as being their primary outcome. But when it was quickly realized that the 3-point MACE effect is pretty modest, and in any study, as you're getting in relative risk reductions in the 10 to 15% range, you could easily miss on the primary endpoint just by a few events. So the DECLARE investigators did something very smart as they decided to construct a dual primary outcome as their dual primary endpoint, I should say. And that's totally legally, statistically, as I understand it, as long as you're making these decisions before data lock, before obviously unblinding of the data. So they incorporated the combination of cardiovascular mortality and heart failure hospitalization as one of their primary outcomes. And it's a good thing they did, because with DECLARE, dapagliflozin did miss the 3-point MACE. The hazard ratio was 0.93, but not statistically significant. But they did hit the CV death, heart failure hospitalization outcome by, I think the relative risk reduction was about 17% in DECLARE. So again, a third trial showing an important impact on heart failure hospitalization. I would also point out that that composite, that CV death and heart failure hospitalization composite in DECLARE, was completely driven by the heart failure hospitalization piece of that composite.
Yeah, and so we see this consistency in a couple of ways. One is the impact on heart failure, but now we go from EMPA-REG to CANVAS to DECLARE, and one could make a good argument that you're talking about a high-risk population, an intermediate-risk population, now a more moderate to lower-risk population, and you see how the benefits associate with the baseline risk, which is, I think, an important observation when we start matching therapy to risk here.
Yeah, many more primary prevention patients in DECLARE. So as you pointed out, the risk was going down as we moved from EMPA-REG to CANVAS and then to DECLARE. And also we should point out that the chronic kidney disease outcome was also reduced in DECLARE by dapagliflozin.
Yeah.
So now we have 3 studies showing a very consistent effect on the progression of CKD.
Yeah, and what's really fascinating to me about the kidney impact is that seems less affected by baseline risk. You see the benefit. It may be attenuated modestly in lower risk patients, but boy, it's really there. And as a cardiologist, at least, that to me is a really important finding, because as we start thinking about the other applications of these drugs, which we'll discuss in another program in heart failure, that renoprotective effect is something to really take into account. Well, we have a few minutes left. I want to mention the most recent study, which in many ways recapitulates the same experience we've seen from the other trials with respect to this risk and efficacy intersection, that being the VERTUS study with ertugliflozin. So what did we see here in this trial?
So ertugliflozin proved negative for their primary outcome, again, 3-point MACE in VERTUS CV. But once again, the heart failure hospitalization result was just as good as with the other studies, about a 30% relative risk reduction. Initially, actually, their progression of CKD outcome proved neutral. The point estimate was 0.81, so 19% risk reduction, but not statistically significant. But actually, they had a bit of a higher bar in terms of what they deemed progression of CKD. And when they reanalyzed the study, using, I forget if it was the increase in creatinine or the drop in GFR, but it was a reassessment using the same CKD outcome that the other trials used. They actually found a very similar effect with ertugliflozin. So once again, we see this consistent heart failure effect and this consistent CKD effect. And I point out that the interrelationship, as you pointed out, Jim, between heart failure and CKD is bidirectional. So not only are CKD patients predisposed to heart failure, but once heart failure is diagnosed, there's an increased rates of the progression of CKD. Now, some of that may be obviously from volume contraction and using potent diuretics, but I think there's an interesting bidirectional relationship between the kidney and the failing heart.
Yeah, and that is just a great segue to our last couple of minutes, where I'm not going to give you too much leeway, because I think the answer is we have really no good idea, but the mechanism of action is something that many of us have sort of struggled to summarize in a single review article. And it's a little bit hard sometimes to summarize because it remains unclear. But what do you think the highest likelihood reasons for why these drugs reduce risk so much might be?
There's so many hypotheses here. I'm a bit simple, and I still think that it's mainly, at least initially, a diuretic effect. I think these are unique diuretics in that they do have a natriuretic property. After all, the S in the SGLT2 is sodium, so blocks sodium reabsorption proximally. And it's been shown that there is an increase in hematocrit when you're using these medications. We went back into the EMPA-REG database and showed that the biggest mediator, at least statistical mediator, of the benefit on CV mortality as well as heart failure hospitalization ended up being that 3% increase you see in hematocrit when using SGLT2 inhibitors. We think this is mainly volume contraction, although there's an opposing view that says that this is related to an increase in erythropoietin that's also been demonstrated with use of SGLT2 inhibitors, presumably effect on energy utilization by the kidney. But I think the verdict remains out. It could be, at least in part, a plasma volume reduction, offloading of the ventricle, improving heart failure outcomes in that way. But that sounds overly simplistic. And there are probably many other mediators of that effect. And we'll find out over the next few years as to which ones they might be.
Yeah, so there's so many hypotheses, of course, and the sodium glucose co-transporter pump is adjacent to the sodium hydrogen co-transporter, and blockade of the sodium hydrogen pump results in increased resistance to tissue injury in the myocardium as well as in the kidney. These drugs restore tubuloglomerular feedback, and so that may be partially related to their benefits in preserving kidney function through effects on the efferent and afferent arterioles. And this intersection, as you said, between the kidney and the heart is just so hard to discount. And really thinking about it, it may ultimately be that there are multiple reasons why they reduce the risk, and that may in part explain why they are so consistently good at reducing heart failure events across a wide range of risk at baseline in these studies. So in the last minute, Silvio, you're a clinician, I'm a clinician. We see similar patients in many ways. We share patients philosophically, at least in terms of the disease states that they carry. In whom do you think SGLT2 inhibitors might be indicated at this stage?
Well, they're clearly indicated in patients with type 2 diabetes who have heart failure or at high risk for developing heart failure. I think they're also very clearly indicated. We didn't get into the CKD progression data too much today, but they're clearly indicated in patients with mild to moderate CKD in order to prevent the decline in eGFR, which is almost inexorable in these patients with progressive diabetes. So those are the two cohorts of patients that I think these drugs definitely should be used. I also think that any diabetic patient, type 2 obviously, with atherosclerotic cardiovascular disease is eligible for SGLT2 inhibitor. Here you get into a bit of a discussion as to whether they should be assigned to an SGLT2 inhibitor or a GLP-1 receptor agonist, which is obviously another category of medications that also has a very similar MACE effect, probably, or I should say, definitely through other mechanisms because they're completely different medications. But at least a rational argument can be made for one drug or the other in the ASCVD patient. But I think once heart failure is present, once mild to moderate CKD are present, in my mind, it's got to be the SGLT2 inhibitor.
Yeah, so that's a great summary for our clinicians. Type 2 diabetic patients, of course, are the patients that were studied in these trials. Patients with type 1 diabetes are at risk for ketosis if treated with an SGLT2 inhibitor, so they should not be treated, as you said. Type 2 diabetic patients with an A1C over 7 or even lower, I have taken to discontinuing sulfonylureas to afford the glycemic headroom, if you will, to avoid hypoglycemia. And certainly those patients with CKD and heart muscle disease are a target-rich environment for being placed on an SGLT2 inhibitor. This is been a great discussion, Silvio. I want to thank you so much, and I hope that our listeners gained from your knowledge and your wisdom. And I have a feeling that there's going to be a lot more to learn about SGLT2 inhibitors in the upcoming years. So this has really been a terrific walk down memory lane and gives us a view of where we're heading in the future.
Very good. Thanks for having me, Jim.
Thanks so much.
Thank you for joining us. Remember to claim your credit and evaluate this program. Please visit morningcommutepodcast.com/SGLT2 inhibitors 4. For all the podcasts in this series, please visit morningcommutepodcast.com/cardiology.